hypoglycemia is a very, very common presentation in terms of clinical practice, especially in the neonatal period and the post-neonatal period. And there are a lot of implications in terms of the pathophysiology of understanding, because that decides about your etiology as well as information about how do we approach and how do we evaluate in terms of investigation. So we'll be spending quite some time in terms of pathophysiology, and then we will move towards the phenomena as to what are the causes and how do we evaluate from there. So from a pathophysiological perspective, what are the key ensures which maintain the blood sugar levels in the body?
First is a regular intake of source of glucose. The second is in stages of fasting where you need your hepatic glycogenic crisis to keep. So glucose storage disorder, glycogen storage.
So first, of course, is the food intake that you take. The second step, which will prevent hypoglycemia, will be glycogenolysis, then gluconeogenesis, and then the fatty acid oxidation defect, which will be there. Now, simultaneously, while you are activating these processes, you will also need to inhibit some of those processes. So which processes will be inhibited if you are fasting? Glycogenolysis will be increased. So glycogenesis will be impaired, your lipogenesis will be impaired. So you're basically going towards a catabolic mode. So all you need to understand is what are the things which increase the blood sugar. If your sugar levels are low, those levels will go up in that perspective. In terms of hormonal regulation, we always talk about that we have got insulin, which is a prime regulator of acting against hyperglycemia. And we have got 4 ones which are acting as a counter-regulatory hormones in that perspective. So if you are developing hypoglycemia, which of these mechanisms you would like to start first? Okay, what else should happen? So if you got less money, what would you like to do? Would you like to stop your spending first, or would you like to get more money, borrow more money from there?
Stop spending first.
So insulin inhibition of insulin will be something which will happen at a very early stage, and that's what we discuss about. So epinephrine, yes, and there are variabilities also as to what level it acts and other factors, but the first cardinal event will be suppression of insulin. So we'll discuss about what levels insulin comes on, but as soon as your sugars are low, the first thing will be to decrease insulin so that you do not waste your sugars. And then you will of course have the counter-regulatory hormones from that perspective. Essentially, the first issue which often people will consider is why is glucose important to us? So glucose is basically important to us because it's a source of energy. It's a readily available source of energy. Now, the major consumers of energy in the body is of course the brain, and the brain is consuming much more compared to any other tissue in that perspective. The other major consumers are the muscular activity, particularly the cardiac muscle, which is continuously working in that regards, and the red blood cells, which are carrying the hemoglobin, so they will need more energy. So these are the major demand areas as far as the energy is required, and this energy will then come from various sources. The most important of this is glucose. Now, glucose is basically used by everybody, including the RBC, including the brain and all the muscles. Now, once your glucose is going off the system, you will start using some alternate sources, and that alternate sources of fuel are ketones, which are used by the brain as well as the muscle to a large extent, particularly the cardiac muscle. So ketogenesis is a way by which you can salvage the brain in the setting of hypoglycemia. So if you have an individual like, let's say, glycogen storage disease versus somebody who has hyperinsulinism with a blood sugar of 20, who would have more neurological manifestation, GSD or hyperinsulinism? So the ketosis process will actually be able to save the neuronal function. So we often see patients with GSD who will have 20, 30, 40 sugars. They will be roaming around. They might not have that many symptoms because they've got enough ketones, which is really preserving the brain. And brain really is the major cause of symptoms as far as hypoglycemia is concerned. Now, then we have fatty acids, which can also be used by the cardiac muscle, but they are used to a lesser extent. So the entire process of lipolysis, which will produce fatty acids, And from the fatty acid, you will get ketones, is responsible for providing us fuels for the brain as well as the cardiac muscle from that perspective. So what we are trying to say is that glucose by far is the most important because it is providing energy to everybody. Glucose is absorbed through the intestine using the GLUT2 and SGLT1. From there, it is utilized via the brain using GLUT1 and GLUT3. And from there, you have got the GLUT1, GLUT3, and GLUT4 mainly in the muscle, adipocyte, and the liver. All of this, a lot of insulin dependency is there as well in that perspective. It is then taken up via the liver. Now, remember, GLUT2 was independent of insulin. So, even if you don't have insulin, liver will say, okay, I'll take more glucose. You don't want to keep it in the blood all the time. And from there, it will synthesize glucose. It will go into the kidneys, again, independent of insulin. You don't have zero insulin, still, you will like to lose in the urine. That's what you want to prefer. That's why even in type 1 diabetes, you will have a lot of glycosuria because otherwise GLUT2 will not be acting. SGLT2 will actually absorb that in that perspective. Now, then, of course, you've got mechanisms when you are hypoglycemic to counter this. You've got phosphorylase, which produces glucose from glycogen, which will then be utilized. You have got SGLT2, which will increase the urinary absorption, decreasing the urinary loss. Then you have got fructose 1,6-phosphatase, which is producing more glucose from a non-glucose source like glycerol, like alanine and other amino acid from that perspective. You also have the alternate source of energy, which provides you enough amount of ketones. So this is the whole mechanism which you can understand. Now, endocrine regulation starts from there. You have got the insulin, which is being produced. So if your body is sensing, okay, GLUT2 and GCK. So these two will be insulin independent and they will say, okay, now your glucose is high, produce insulin. Insulin will say, produce more glycogen, inhibit glycogenolysis, inhibit gluconeogenesis, inhibit ketogenesis. So this is the hypoglycemic arm. Then glucagon will mainly say, okay, liver produce more glucose from glycogen. Then you have got growth hormone mainly acting at the level of lipolysis, and then you've got the adrenal hormones, cortisol, acting mainly at gluconeogenesis, and epinephrine at the level of phosphorylase, as well as at the level of the adipocyte. So this is the entire picture. If you understand this, a lot of things becomes much, much easier. So what will happen during fasting? During fasting, when your glucose becomes less than 50, and of course, some people talk about different cutoffs at different age, when you have hypoglycemia summary, the first thing should be your insulin production should be shut down. If you have no money, stop spending. That's the main thing. Then you start borrowing. So insulin should be undetectable. You should have a very robust response in terms of cortisol and growth hormone. So cortisol should be above 550 and growth hormone should be above 10 nanogram per ml. You should have a high glucagon level. So giving additional glucagon should not be working unless you have got a hyperinsulinism as a scenario. 6 to 10 hours, you will have glycogenolysis, which is happening. 10 to 24 hours, gluconeogenesis will take care of it. And ketogenesis should become, so everybody who is hypoglycemic should produce ketones more than 2 millimoles per liter. Less than 0.6 is non-ketotic hypoglycemia. 0.6 to 2 is hypoketotic hypoglycemia. And this will help you out from 12 to 24 hours in that perspective. So as I said, if you are already fasting and you have hypoglycemia, giving glucagon will not work. But if it works, you will have hyperinsulinism as a possibility. Now, what happens when you have eaten a food? So here you will go into that anabolic process. So you will have high glucose, high insulin, and your entire process will be there. So high insulin, low glucagon. This is your classical anabolic pathway. You will have more amount of glycogen, more amount of proteins because they are not being used to produce glucose, and more amount of fat which is there, and you will not be having that much growth hormone and other perspective in that regards. So we talked about the various pathways, largely the glycogenolysis, gluconeogenesis, and ketogenesis. Now, if you increase the duration of fast, the relative contribution changes. So if I talk about 6 hours, it's mainly glycogenolysis, 80%. At 12 hours, your gluconeogenesis is also coming into the picture. But at 24 hours, your ketogenesis and other factors are more important. By 36 hours, your glycogen is used out, your other stores are used out, and then you really become ketotic. So that is something which is extremely important. So if you are starving, would it be better to be obese or lean? Because you will produce more ketones in that perspective at the cost of becoming acidotic. But that is all right, because otherwise you will starve. So getting that ketones is also important from that regards. So now if we just summarize about the hypoglycemia timeline and reactions, as I said, the first thing will be insulin release, which will happen very early. So as soon as the levels start go above 100, your insulin release will come into the picture. It will get decreased below 80. So as I said, when we talked about DI, that when your osmolality goes above 283, your AVP comes into the picture. Thirst will come into the picture 10 more. So you don't want to drink and pass. You want to first stop your urine and then start drinking. Same here, so reduction in insulin secretion. Then you have got the various pathways. Some people will say there is here and there, but mainly the counter-regulatory will come a bit later. Then you will have the neurogenic symptoms. High epinephrine will cause sympathetic symptoms, and then you will have the neurogenic symptoms. And zero release will happen around 50 to 60 in that regards. And then you will start having the neuroglucopenic symptoms. So neurogenic symptoms are tremor, palpitations, sweating. Neuroglucopenic will be like altered sensorium, seizures, and other parameters. And finally, you will have neuronal damage from that regards. So based upon all that we have discussed, we need to understand that there are different time by which you can tolerate a fast. And this will be important when you're doing an induced fast. A normal neonate should be able to fast for how long? After the age of 2 days. So generally 4 to 6 hours. So they can skip a meal. This is what is important. So when you're discharging a neonate from your hospital, we often say you give a challenge. You skip a meal and see whether the child is able to tolerate that or not. So neonate typically 6 hours. 1 month to 1 year, it's going also towards a higher side. And typically by 5 years, it's like 2 days. So generally 1 year should be able to have a fast of around 24 hours. So the ketotic hypoglycemia, the accelerated starvation, what happens is their stores are less. So they tend to use it up earlier, and that's why they become hypoglycemic. We know that glucose is very, very important for everything in the fetus. And fetus is completely dependent on the mother with regards to the glucose level. So all the needs are coming from the mother with no intrinsic production. So there is a gradient which is basically maintained, but this gradient is not an active process. It is against a GLUT. So it's a facilitated diffusion. So fetus glucose will always be lower as compared to the mother. So GLUT1, GLUT3 will be there. So what fetus will require to do is to increase the level of glucose in the mother, so that they will be able to get a good amount of glucose. So what they do is that they induce insulin resistance. How do they induce insulin resistance? So what happens is that this insulin sensitivity is decreased via the human placental lactogen. That's why you have got so much prevalence of impairment in terms of glycemic control during pregnancy. Somebody who was well controlled suddenly becomes uncontrolled. This is all because of these hormones of pregnancy, which make it very, very important from that perspective. Now, in that regards, this glucose will then trigger insulin production in the baby, and it will inhibit glucagon. So high insulin, low glucagon. What will it do?
High insulin.
So all the fetal growth, fetus is there to grow. It doesn't need energy at all. So it will keep on growing. This causes fetal growth and glycogen deposition. Maximum deposition happens in the last trimester. And that's why if you have a preterm baby, they will have less amount of glycogen and they will have a higher risk of hypoglycemia in the transitory period, so to speak. Now, what happens at birth? Suddenly all the supply goes off. So what you will do first, you will start producing epinephrine, you will stop your insulin production, and you will increase your glucagon. So from an anabolic process, you're going more towards a catabolic process suddenly, and you start using your glycogen. So in the first Day or 2 days, you will use your glycogen, then your gluconeogenesis, lipolysis, and ketogenesis will be a delayed manifestation. So blood ketone production is unusual in the first day of life. So if you have a hypoglycemic child and you somehow, we should not measure all the workup at that time, and you get a ketone level done in the first day, it will be hypoketotic. So that does not mean that this child has a hyperinsulinism in that regards. You also have increased expression of GLUT, so your supply to the brain and vital areas is also being tried to counter in that regards. Despite all these changes, you will have a drip as far as the glucose level is concerned, with a peak dip or a nadir which happens around 2 hours of life, and then by around 48 hours all your mechanisms are intact. So beyond 48 hours, neonate is adult as far as the mechanisms for glucose control is concerned. Of course, the duration of fast will be different because of the limited stores that they have from that perspective. So now what does hypoglycemia do? If you have hypoglycemia, there are two types of symptoms. One is because of the neuroglucopenic, where brain is not getting enough glucose. You have headache, jitteriness, seizures, apnea, coma, ataxia, which are autonomic symptoms, which are more like neurogenic symptoms, which include sympathetic symptoms like palpitation, tremor, and anxiety, and parasympathetic symptoms like sweating, hunger, and paresthesia. So it's a combination of both. Somebody who has a long-standing hypoglycemia, which symptoms will go? Neurogenic or neuroglucopenic? Will not be felt by that particular patient. So this is what we call as hypoglycemic unawareness, which is particularly common in type 1 diabetes in that perspective. So this is something important. And of course, because muscles are also not working, you will also have myopathy. So many of these hypoglycemic storage disorders like GSD3, 6 may come more with myopathy, high levels of CPK, failure to thrive, hypotonia. This will be the scenario, and sometimes even the cardiac failure. So we will just finish on this slide and we'll take etiology on the next session. So problems of hypoglycemia.